Let me see each one of you.
Sure, sir.
Namaskar. Hi, કેમ છો?
All good, sir. Thank you. After sir.
Okay. Yeah, બોલો આયુર્વેદ તમારું newspaper.
All right, sir.
Okay. Golden Gate Bridge. Hi, how are you?
Fine, fine. Not a problem.
So over here, I give send a reminder to all our audience to remind their respective pet.
Sure, sir. On it.
ठीक है चलो I will mute them.
I just came back from a meeting in Montreal, and I can tell you the technology and the way that webinars and everything are conducted here is much better than in Canada. They had so many technical glitches there. So I'm very happy to be back in India.
Yeah, absolutely.
To know, ma'am.
Although we are a third world, but when it comes to digital way ahead, in that India is really booming. And we do have companies like Infosys and TCS who are actually having a lion's share when it comes to digital.
Absolutely. So it was very heartening when Dr. Alok Srivastava was there, and he was also frustrated because it was a hybrid platform and all the online webinars had so many technical problems.
Hello, Sanjeevan sir. Good evening. And hello, Dr. Nitin. Good evening.
Good evening.
Hi, good evening.
Hello, nice to see everyone. So Dr. MB again has made a beautiful case and really interesting. Looking forward to tonight. Hello, Dr. Biju. How are you?
Hi, Sanjeevan.
Good evening, Dr. Hello, sir. So I was just telling them I'd come back from Canada from a very big meeting, and I was telling them that there have been so many technical problems with the online platforms, and almost every online blog had some issues. So I was so happy because I think in India we are so good.
I should be very happy.
Yes.
I'm just hoping that it doesn't rain. In the last few days, it's been heavy rains, and when it rains, the power, everything shuts down. I'm hoping over the next 1 hour, nothing happens.
We have the same issue in Delhi. But fortunately for us, it rarely rains. But when it rains, we don't know how to deal with it.
Good evening, Sharad sir and Biju sir.
Hi, good evening.
Good evening, good evening. Hi, Biju.
Hi, Suresh.
Hello.
Good evening. Biju sir, since we have 2 minutes time, let me remember I had to mail to you. I had actually match and slight protocol. That is work dramatic on this. So sometimes just a little tweak here and there can. This guy who's hanging around with a DLC of 1,500 is now sitting with a ANC of 2,000.
Okay. But I mean, I wouldn't just credit the MMF alone. I think part of it is also probably a late effect of the ATG. Because sometimes we've seen patients where
It's around 8 months post ATG.
Yeah. We've seen
8
people
months.
where it actually starts working at
1 year.
1 year. So it may be a late effect of that, but it's probably a combination. We all learn out of necessity, not trials. one.
But in
It's just doing the analysis.
okay, sir, that's fine. And you're using on day plus one, sir?
So we start the Romi and we use a cytokine cocktail of Romiplostim with EPO and Tenji.
Okay, sir.
Our patients are all engrafted by day 10.
And you're using this cocktail at day one.
We start day 1, 2, 3. Come, I'll just show you the protocol.
Sure, sir. Please share
We
that.
started it out of necessity during COVID, but we've now finished almost 120 patients. So we are actually doing an analysis comparing it with the time when we didn't use anything.
Yeah, we've also been adding it on day 3, which was again on the necessity with the tech G and I think it certainly helps in both ways.
It's been a good word about multiple arrows.
Yeah, I think Kalpesh has put 1 minute to go, but I will request Dr. Roshan. I think all the faculty members are in except 2 of them who will be part of panel. So maybe we can start.
Yes, sir. So, sir, I will just give brief introduction of Alchem and Engine, and then I will introduce all the faculties, and I will hand over the session to today's chief guest, Dr. Sarat. And then that's okay to everyone.
Yeah, please, please.
I will, on behalf of Alchem and Mumbai Hematology Society, I will like to welcome you all on today's webinar on Romiplostim-based treatment in ITP and beyond. I am Dr. Roshan Pawar. I am heading medical affairs at Alchem, and from all my team members, I will like to welcome all the faculties and delegates for today. I will just take a couple of minutes to just give brief introduction of Alchem and Alchem's presence in oncology, especially hematology. So Alchem, with considering future, has acquired a biotech company called as Engine Biosciences almost 10 years ago, and it's now a fully owned subsidiary of Alchem. And Engine is different from others that it is a fully integrated process development capability, and a platform which Engine uses is a continuous biomanufacturing platform, which is different from a traditional fed batch culture. And because of this platform at Engine, we are able to produce a good quality product and in much more quantities, so that for the Indian patients, the accessibility and affordability issue can be taken care of. And that's what a differentiation at Engine we can deliver. And with this, after 8 years of hard work, we were able to launch our first 2 biosimilars, that is Romiplostim and denosumab. We are very proud to say that our denosumab is being also developed for the global like US FDA and Europe markets, and currently it is in phase 3, phase 1 and phase 3 clinical trials are ongoing in Europe. Apart from that, we are also quite ahead in the development of few other biosimilars, and in near future we will be coming with cetuximab, bevacizumab, which are almost on the verge of completion of trial. And also we have a rich pipeline where we are planning to have pertuzumab, nivolumab, and other important monoclonal antibodies for India as well as for global development. So this is about us, Alchem and Engine. For today's program, I would like to welcome all our faculties. First of all, our chief guest today, Dr. Sarat Damodar, who is a clinical director at Majumdar Shaw Medical College and head Head of Hematology and BMT at Narayana Health City, Bengaluru. Welcome, sir. I would like to welcome our today's moderator, Dr. M.B. Agarwal, sir, who is Professor and Head at the Department of Hematology, Bombay Hospital, as well as he is Consultant Hematologist at Lilavati Hospital, Bridge Candy Hospitals, Mumbai. Welcome, sir. Today's lecturer for the talk on Romiplostim, we have with us Dr. Biju George, a professor at the Department of Clinical Hematology at CMC Vellore. Welcome, sir. And for our panel discussion, we have eminent panel group. I will like to welcome Dr. Neeraj Siddharthan, Dr. Nitin Sood, Dr. Padmaja Loki Reddy, Dr. Sachin Jadhav, Dr. Sandeep Shah, Dr. Sanjeevan Sharma, Dr. Tulika Seth, and Dr. Sanjeev. Welcome all, and I will like to hand over today's session to our chief guest, Dr. Sharad Damodar.
Thank you, Dr. Thank you, Dr. Roshan. And I'd like to start by thanking Alchem and certainly the Mumbai Hematology Group and Dr. M.B. Agarwal for actually inviting me for this. And clearly, I think all of us are privileged, both as consultants and as postgraduates, to have this facility to actually listen to these lovely lectures and topics and CMEs on this online platform. Just before the meeting, Dr. Tulika mentioned that, compared to what happens in the West, the quality is so good here. And I think we're really lucky that we're able to listen to so many talks, both national and renowned international speakers. And this is a big plus to all our postgraduates. And I'd like to certainly congratulate both the Mumbai Hematology Group and Professor Agarwal for doing this. I was just going through some of the Guinness records the other day and found that the longest medical lecture apparently is 30 hours. But I don't see any name for the largest number of CMEs ever conducted by any single doctor. So I think certainly Dr. MBA will qualify for that. And sir, I think you should try to pursue your name into those records. On a lighter note, coming back to today's topic, this has a close association with me, close to my heart, because right from my PG days, ITP was my thesis, and we have Professor Biju, who was also one of the guides at that time, who chased me to collect data in ITP, and we came out with this publication on the dapsone data, a reasonably good number, and the first publication from India, which is often quoted. So it's nice to go back to those days, and this is a message to the postgraduates that when you're in training, please get your data together and publish, because it'll never happen otherwise. And this certainly helps me in good stead even as of this day. We're lucky that Dr. Biju is one of the speakers today on ITP. We've come a long way from dapsone to Romiplostim. And with that, I'd like to get the talk going back to the organizers. Thank you.
Shall I start? Thank you, Sharad, for the introduction. I will just briefly, I'll just share my slides. Are my slides visible?
Yes.
Okay.
Yes, sir.
Okay. So what we are looking at is just a synopsis of Romiplostim in the treatment of ITP, and I'll talk a little bit about beyond ITP. We all know that ITP is a very common disease even in India, although we do not have India-specific demographics. It's believed to occur in about 6 per 100,000 children and 3 per 100,000 adults. We have what is called as primary ITP and secondary ITP. Primary ITP is still immune-mediated, but we do not have an etiology for it, and it causes about 80% of cases. ITP right now is classified based upon its chronicity into newly diagnosed, which is between 0 to 3 months, persistent, which is between 3 to 12 months, and beyond 12 months, which is chronic. This is actually data from the West, where it shows that if you look at the number of patients, when you go above 60, the ITP epidemiology goes up. I would assume that if we actually had data from India, we would be following into the range of 30 to 50 years, where would be a major group of patients. And when we look at the pathophysiology, we all know that the macrophages present platelet-related antigens to the cytotoxic T cells. There is proliferation of cytotoxic T cells, which leads to stimulation of plasma cells, formation of antiplatelet and megakaryocytic antibodies. which cause phagocytosis in the macrophage. Along with that, what is important to remember is that even cytotoxic T cells directly cause T cell mediated platelet destruction and inhibition of megakaryocytes. Using both these pathophysiologies, our general understanding has been the use of corticosteroids, intravenous immunoglobulin, the use of splenectomy, rituximab, and other T cell agents like azathioprine and cyclophosphamide. But one of the important things to remember, especially in adults, is the fact that when we look at long-term remission, we would see only in about 20 to 30%, although initially 50 to 60% would respond. What is important is the fact that native thrombopoietin acts through the thrombopoietin receptor and causes activation of the JAK-STAT pathway. So if you use any agonist that can stimulate this pathway, that will help in improving megakaryopoiesis. Now, this can happen through two agonists. One is Romiplostim, which acts mainly on the extracellular domain, and two is L-thrombopag and also avatrombopag, which acts mainly on the transmembrane region and then causes the JAK-STAT pathway activation, leading on to signal transduction and subsequently to platelet production. So if you look presently at the algorithms of management of ITP, this is what happens in newly diagnosed. But subsequently, once you fail this therapy, you are looking at either medical or surgical, and the robust evidence is for Romiplostim, L-thrombopag, and rituximab, less for this. And I go back to what Sharad said, one of the main reasons why there is less evidence is that the evidence is just not published. And I think if you look at India, there must be at least 5,000 to 10,000 cases of ITP which have been treated with either azathioprine or dapsone, because it doesn't lead literature, it doesn't get included. And of course, splenectomy is a surgical option. So if you look at the ASH recommendations, once you reach either persistent or chronic ITP, there is always a role for the use of TPO agonists. If you want a durable response, you look at TPO agonists, but it consists of long-term medication. So if you want to avoid long-term medication, you would probably consider using rituximab. Even when you look at more than 12 months, it depends upon patient preference, whether you want durable remission, whether there is TPO agonist or splenectomy, whether you want to avoid long-term medication, again, rituximab or splenectomy, or you want to avoid surgery altogether, then TPO agonists or rituximab. So depending upon what is the patient preference, and it's a conversation with the patient, you can decide what would be the drugs that you use. Now, the use of TPO agonists, how did we reach these recommendations? So if you look at both Romiplostim and L-thrombopag, FDA approval is for adult and pediatric patients with ITP who have insufficient response to corticosteroids, IV immunoglobulin, or splenectomy. L-thrombopag also has additional indication in terms of chronic hepatitis B associated hepatitis. So what are the studies on Romiplostim and ITP? The initial publication was in NEGM 2010, where they looked at patients who had ITP who did not undergo splenectomy, and they were sort of divided in a 2:1 ratio to subcutaneous Romiplostim was the standard of care. They started with a dose of 3 microgram per kg weekly, going up to 10. Treatment duration was for about 52 weeks. And what they wanted to look at what was the incidence of treatment failure and what percentage went on to having a splenectomy. So in the Romiplostim arm, about 11 patients had treatment failure, while it was 30% in the standard of care, and about 9% required a splenectomy with Romiplostim as compared to 36% with standard of care. They also looked at the duration and in terms of how well maintained the platelet counts were. And what they found was that the mean platelet count was maintained at a good level with Romiplostim over the 52 weeks. He also looked at safety. The occurrence of serious adverse events were 23% in Romiplostim and 37% in standard of care. So the conclusion was that it resulted in a consistent and higher rate of platelet response, lower rate of treatment failure, lower rates of splenectomy, lower bleeding rates and fewer transfusions, and improved quality of life care. There also was two other parallel prospective studies looking at its use both in splenectomized and non-splenectomized patients in a 2:1 ratio of romiplostim versus placebo. Here they started at a lower dose of 1 microgram per kg and adjusted to reach a platelet count between 50,000 to 200,000. So if you look at durable responses, it was about 61% in non-splenectomized as compared to 38% in splenectomized. The durable response meant that you had a platelet count for above 50,000 for the last 8 weeks, at least 6 times, while the overall response was about 88% in non-splenectomized versus 79% in splenectomized. When you look at rescue medication, roughly about 60% in the placebo arm required rescue medication as compared to about 20 to 25% with romiplostim. So again, here the conclusions were that romiplostim caused stimulation of platelet production, which helped in increasing and maintaining the platelet counts, both in splenectomized and non-splenectomized. They were able to reduce or discontinue concurrent ITP medication, and it was very well tolerated. The third was data from studies looking at durability of response. So this was an open label extension study of the original study and 4 cohorts that were followed up. This consisted of a total of 292 patients who completed previous romiplostim studies. The duration of treatment ranged from 1 to 200, that is 5 years, for a median of 110 weeks. And what they showed was that the mean romiplostim dose sort of was maintained for most of the patients, and the median platelet count actually could be maintained and was stable over a period of time. This is totally about 5 years. So a durable platelet response was maintained with stable dosing up to 5 years of continuous treatment. Romiplostim was safe and well tolerated over 614 patient years of exposure in patients with ITP. Now, when they looked at subgroup analysis, they looked at patients who had ITP for less than a year, for more than a year. More than a year would qualify as chronic ITP. And they showed that the responses were about 74%, 75% of the time. It dropped to about 62% when it was more than 90%, and durable response was in about 50%. There's also some data in children. So this was a publication in Lancet 2016, about 62 patients, 42 romiplostim, 20 placebo at 1 mic per kg, and about 70% showed response with a durable response of 52%. And in the long-term extension of the same study, the total response was 94% with the treatment-free response of about 23%. This is data from the generic romiplostim. They did a study on 52 patients in a 2:1, 3:1 ratio of comparing with the innovator romiplostim. The study duration was 24 weeks with a treatment duration of 12 weeks and a follow-up for another 12 weeks. Essentially, they showed response in about 83% as compared to 76% with the standard end plate. It was similar in both groups, and with the durable response was about 56% as compared to 38%. So if you look at the primary analysis, response rates were good. It was a non-inferiority study in terms of the response rates, and the safety analysis was also good in chronic ITP. So in general, you would use it, start at 1 mic per kg subcutaneous, and you go by weekly doses until you reach above 50,000 to reduce the risk of bleeding. In general, in ITP, you don't go beyond 10 mics per kg, and most of them would maintain a platelet count above 50,000 at 2 to 3 mics per kg in those who have shown a response. So can we go beyond ITP? The second is chemotherapy-induced thrombocytopenia. Now, why is this important? This is more important in solid tumor-associated cancer therapy, not in hematological, because for us 99% are all thrombocytopenic. But if you look at solid tumors, patients who receive either platinum or gemcitabine based regimens have about 16 to 30% of treatment related thrombocytopenia. Now, when they have this, what happens is that leads to relative dose intensity reduction. And when it leads to dose intensity reduction, that has been shown to directly affect progression-free survival and overall survival in colorectal, ovarian, and breast cancers. Now, based upon the kind of therapy, roughly in platinum and gemcitabine basis between 20 to 25%, where the anthracyclines is less, and that reflects the kind of cancers that you are treating. And so you get chemotherapy dose delays, you can get an increased risk of bleeding and an increased need for platelets transfusion. So prospective studies have shown from small numbers to large that using between 1 to 3 micrograms per kg, about 87% achieve a response, with 73% achieving platelet counts above 100,000 and helping to continue with full dose chemotherapy. This has been there both for solid tumors and some hematological malignancies like lymphomas. And so it's important to realize that even in patients, if you get a consult for somebody who's got solid tumor and thrombocytopenia, this is a drug that may worthwhile be used. So this is again the same data. And so this is data which is from multiple centers put together in various GI malignancies, non-small cell lung cancer, glioblastomas, essentially showing that between 70 to 80% will show improvement, and the dose reduction that you need to do occurs in only about 10 to 20%. So this is again a phase 2 randomized trial of Romiplostim versus just observation in patients with solid tumors with cancer in chemotherapy-induced thrombocytopenia. And if you see here, with the use of Romiplostim, you see this nice improvement in platelet counts, while for the initial 6 to 12 weeks, they did not have an improvement. So Romiplostim rapidly increases platelet counts. It helps scheduling anti-cancer treatment on time and reduces dose delays and decreases bleeding risk and decreases the need for platelet transfusions. The third is the role in aplastic anemia, and all of us are familiar with aplastic anemia. 3 to 6 cases per million in Asia. Thrombocytopenia is a major cause of mortality and morbidity, especially in severe aplastic anemia. And the important thing to remember is that right from the hematopoietic stem cell down to maturation, the thrombopoietin receptor is actually present. And that is probably the reason how TPO agonists work even in a disease like aplastic anemia. Now, the initial data that was generated was all from L-Thrombopag, including the randomized studies. But subsequently, there have been studies from Japan and Korea looking at refractory aplastic anemia and showing that it is useful. And you have, like the L-Thrombopag in aplastic anemia, you have to go to a higher dose of 10 to 20 mics per kg. So this was the original publication in 2019 from the Korean group, where they did a dose finding followed by a long-term treatment extension study. They took adult patients with aplastic anemia who have previously failed at least one course of ATG cyclosporin, and then they started with multiple doses of 1, 3, 6, or 10 micrograms per kg for 8 weeks. And then based upon the dose that they were showing response, they went up and continued that for up to a year. Now, essentially what they showed was that the platelet response occurred best in patients who had 10 microgram per kg, and the responses were not very good when used 1 to 3 micrograms per kg, which is actually the standard dose you would use in aplastic ITP. And these responses were maintained in about 30 to 40% even as you continued the drugs. There was improvement in both the platelets, the hemoglobin, and the absolute neutrophil counts, showing that there was a pan response with Romiplostim, as you see with L-Thrombopag. Subsequently, there were other studies, again looking at 10 mics per kg, showing that roughly between 60 to 80% will actually show a response, with 75% showing transfusion independence. There have been 3 studies which have also looked at L-thrombopac refractory aplastic anemia and showing that at least one lineage response occurred in 76%, and in 48% there was a platelet response, again at doses of 10 to 20 microgram per kg. So how do we put this all together? So I'm just giving an illustration of one of the cases that we had recently. This was an 18-year-old male evaluated for anemia or diagnosed of aplastic anemia. He was already on treatment from outside. He was symptomatic for hip pain. And when he came for evaluation, he was found to have a bilateral AVN, grade 4 in the right hip, grade 3 in the left hip. Was seen by orthopedics, they advised surgery. He was on treatment with cyclosporin, partial response, hemoglobin 7.2, white cell count of 1400, platelets of 18,000, no bleeding. But he needed surgery. And at this level, it is very unlikely that we would get major platelet increments. We couldn't take them up in such a way and to sustain it. So what we did was to add on danazol to the cyclosporin and then see whether that will help in improving the platelet counts. But that showed only a mild improvement. And so we added Romiplostim at 500 micrograms per kg weekly. So by the time we started the Romiplostim, if you look right at the bottom, it was about 36,000. And within about 4 to 6 weeks, we got a good improvement up to above 1 lakh. We continued it. He went through surgery. Post-surgery, we maintained it for about 2 weeks. And then we actually stopped it and just continued the cyclosporin and danazol. He's doing very well with platelet counts hovering about 80,000. So these are some of the things that we can do locally in these patients. The second, what we are doing right now is we are doing a randomized trial like the ATG cyclosporin L-thrombopac. We are actually doing a randomized trial comparing ATG cyclosporin with ATG cyclosporin Romiplostim for 3 months and ATG cyclosporin with Romiplostim for 6 months to see whether the addition of Romiplostim will actually help in improving the outcomes as compared to using just ATG cyclosporin alone. There is also data on the use of Romiplostim and L-thrombopac post-transplant. This is a publication in BBMT in about 86 patients with persistent thrombocytopenia after an allogenic transplant. And this is on allogenic. And what they did was to give Romi or L-thrombopac, and they found that 72% had a recovery above 50,000 at a median of about 6 to 6 days. So it takes a bit of time, about 2 months to find the response. But in majority, even after discontinuation, the platelet responses continued. In about 2%, they had liver abnormalities and fatigue. So they said that for isolated thrombocytopenia post-hematopoietic stem cell transplant, it is actually very useful. So this is a protocol which came out of necessity. We were continuing to do transplants during COVID, but we had a lot of shortage of donors for transplant. So we pulled out and modified a protocol from the Jehovah's Witnesses. Jehovah's Witnesses, as you know, do not use any blood or blood products. So we used a combination of erythropoietin given every 3 days, 1 dose of PEG-GCSF on day +2, and Romiplostim at 5 mics per kg once a week. We have completed more than 100 transplants with this. We are in the process of evaluating, but our gut feeling is that both the thrombocytopenia and the neutropenia recovered about 3 to 4 days earlier than the time when we were not using this protocol. So in conclusion, thrombocytopenia results from a variety of conditions, including autoimmune disease, radiation chemotherapy, bone marrow disorders like aplastic anemia, and after a transplant. In addition to its efficacy in ITP, studies have shown that Romiplostim is effective in improving platelet counts in various other settings, and approval has been received for aplastic anemia in Japan and Korea. And so it's important for us to study its efficacy in many of these disorders. So with this, I will close and I'll be happy to take any questions if any.
Biju, can I ask one question?
Yes.
Biju, in people who respond in ITP with Romi, is there any plan for a taper, on either dose or, frequency?
If you look at the data now, they say continue it. But within the studies, there have been patients. So in terms of the dose, people say you can reduce the dose where you maintain a platelet count about 50,000. And the data seems to suggest that in adults, 2 to 3 mics per kg is enough. Now, the question in terms of whether we can stop it, that in many of the studies, people have actually stopped it because they just got tired of it. And roughly about 30% will show a sustained response. That means a lot of them will drop, but at least 1/3 will continue to show a sustained response despite stopping the drug.
So is there a rule to change from weekly to once in 2 weeks taper kind of thing?
There is no recommendations like that. Yeah, there's no data.
Yeah, right.
Yeah, Sanjeevan.
Yeah, hi. Sir, just following up with Dr. Sharat's question, which is pretty common in our part of the world, that people will just stop treatment in between. The moment they'll see their platelet counts, whether it was for cost factor, convenience factor, whatever be their reason, they'll just discontinue. So has there been any observational studies if you suddenly stop Romiplostim that there is a crash which is more pronounced than would it had we tapered it off?
So there are different recommendations, but the general recommendations are that you have to give it for at least 6 to 8 months. So it is 42 to 52 weeks that you need to give before you try stopping it. If you stop before that, the chance that it will drop is very, very high. But I don't think, there is one prospective study which is looking at stopping it, but we do not have that data yet. Are there any other questions?
So can I ask a question? Neeraj, sir, what about thrombosis? What's your experience on thrombosis?
We haven't had it, but I was just looking up. So I think what they said was when you use it long term, there is a 2% incidence of thrombosis that occurs with Romiplostim. So the incidence is actually very, very low. And they say this is when you use it for more than 8 to 12 months. So it's in the long-term arm.
Has it got a relation with the thrombocytosis? Sometimes you have overshoot of thrombosis.
In that paper, whatever was there, they have not mentioned the correlation with how high the platelet counts went before the thrombosis occurred.
Thank you.
Okay, if there are no other further questions, I will hand it over to Dr. M.B. Agarwal to go ahead with the panel discussion.
Loki Reddy, Hyderabad, Dr. Sandeep Shah, Ahmedabad, Dr. Sanjeev, Lucknow, Dr. Sanjeevan Sharma, Lucknow, and Dr. Tulika Sheth from Delhi. Everybody knows them, so I'll not go into the details of their introduction. So we'll begin with the case 1. I'll address it to Dr. Nitin Sood and Dr. Padmaja Loki Reddy, but all of the panelists are free to answer and add to and contribute to the answers. So the first case is Priya, 32, resident of Delhi, weighing 50 kg. She's advocate by profession. She has primary chronic ITP for last 1.5 years. During these 1.5 years, she has had skin bruising, epistaxis, gum bleeding, and menorrhagia off and on. So she's frankly symptomatic. She has been treated with variable doses of steroids, brief courses of mycophenolate, dapsone, and azathioprine. She now sees you for the next line of treatment. And by various consultants, she has been offered 3 options. Some have offered rituximab, others have offered TPO agonists, and some have offered splenectomy. So she has 3 options in front of her. So the first question is, what will be your first option between these 3? And whatever you select, justify why you have selected one over the other. So Nitin or Padmaja?
Sir, I'll start. Good evening. And I was just saying the first thing we need to do is confirm that it's ITP, because there are other reasons, but I'm assuming that's not the question. And if we were to choose between 3 options, then the discussion between the doctor and the patient has to be a long one. Earlier, a long time ago, splenectomy was the preferred option, but since then, rituximab came in, and that sort of became the go-to therapy. But now TPO agonists have taken over. But all 3 need to be discussed. If she places a high value on a one-time surgical procedure that can offer her a long-term cure, then rituximab is the preferred. Splenectomy is the preferred option. If she needs to know that rituximab gives you remissions, but they're generally not that long-lasting. So the therapy has to be repeated. Plus, in the COVID times, rituximab has at least the theoretical effect of blunting the vaccine efficacy. So there's the downside there, which is why TPO agonists have become the preferred option now. So I think she needs to know all this and make a decision between the 2 TPO agonists, which is your next question. And Romiplostim and Eltrombopac, I think the choice really used to be cost, but now since generic Eltrombopac is available, it's the route of administration. So whether she wants to do once a week injection or whether she wants to do empty stomach once a day tablet. And sometimes people have strong preferences for one of those. So that also needs to be discussed.
Thank you. Very well said, Nitin. Dr. Padmaja?
Yeah, hello, sir. Thank you for the invite. I very much echo a lot of thoughts from Nitin. I want to add on a few things, if I may. So she's young and she has used a lot of steroid. I would like to know what is her baseline platelet count in first place. That would make a huge difference how I would want to focus on this treatment options. If it's a single figure, or if it's a double figure. If she's below 10,000, the next question comes, if she has used a lot of steroid, she has knocked out her B cells, probably the response rates from rituximab is not going to be 50, 60%, the way we would explain in the very beginning. So I would discuss that option with the patient, definitely a patient-doctor discussion about these. And doing a splenectomy in patient less than 10,000, in an advocate, you have to look at the risk and benefit, whether we could give TPO agonist and then followed by splenectomy if she would want, but it is going to be a risk of thrombosis. So I would favor a TPO agonist if she's got a below 10,000 to get her into a safer levels. And discussion between Romiplostim and Eltrombopac is all purely about whether tablet form, injectable form, and whether it with her work, whether the diet modifications, whether it will all work for her, and being realistic about the duration of response. So these would be the discussions. And splenectomy, I would keep it to the last resort in the current time.
Thank you, Dr. Padmaja. Dr. Tulika Sheth?
So I think this has been very well answered. I just wanted to throw in a little point extra. So rituximab, the data suggests that females, particularly in the reproductive age group and who have not had ITP for very long, that is probably less than 2 years, have a much better response to rituximab. So we just need to make sure that we give this information to her, because it's better to use the rituximab now rather than wait for a year or 2 and then use it down the line. She will always have the option of the TPO receptor agonist, but this would be a good time to offer her that type of information. Obviously, she may opt to go for TPO receptor agonist because of toxicity and other situations as well, but I just wanted to put that information there.
Thank you, Tulika. Sanjeevan?
Sir, I just like to re-echo thoughts which Dr. Padmaja had already mentioned, that splenectomy is something which actually I may discourage as a hematologist rather than, using it as an option. not just because she's a young lady, but in current era, I mean, splenectomy was an agent used when we did not have so many options. So in current era, using splenectomy right now may not be the most suitable way forward.
Wonderful. I don't see any other raise hand sign, but if somebody wants to add anything, you're welcome. Okay, so we'll move on a little. So I'd like you to take through this flow chart. So when you have this kind of situation of a chronic refractory ITP, which has gone on for quite some time, and the patient is frankly symptomatic, bleeding from various sites throughout the year, these are the three main options which we put forward: rituximab, splenectomy, and TPO agonists. So obviously, as I said, assess the patient values and preferences. So that is most important. If the patient places a high value on achieving a durable response, then rituximab does not feature there. Because rituximab, the median duration of action is 1 year. So durability is not there. So you've got splenectomy and TPO agonists. If the patient places a high value on avoiding long-term medication, so as you just heard from Dr. Biju, that TPO agonists are long-term treatments, years sometimes. And in 70 to 80% of patients, it may be lifelong. So in that case, if she doesn't want long-term medication, it will be rituximab and splenectomy. While if the patient just doesn't want surgery, then it will be obviously rituximab and TPO. Further splitting, which is in fact a duplication of what we have just said, that if patient has got a very important aspect of durability of the response, but she doesn't want surgery, then she has to go on TPO. If the patient does not want long-term but a durable response, then she has to go for splenectomy. If the patient wants to avoid long-term medication and doesn't want surgery, she has to keep taking rituximab every year. And if she doesn't mind surgery, then she goes for splenectomy. And if surgery is out for her and she's choosing between rituximab and TPO, then if she wants a stable response, then TPO. And if she doesn't mind giving a repeated injections, then rituximab. As far as the second part of the question was concerned, Eltrombopag versus Romiplostim, and it was very well covered by Nitin, the advantage of one over the other. Dr. Biju told us how the site of action of the two differs. Romiplostim is the ligand binding domain acting, and the Eltrombopag, and the new one which we don't have, Avatrombopag, is acting at the transmembrane domain. But that does not matter, except one aspect of it, that one can combine these two, which is not done in the Western world because of the cost. But as the cost has come down in India, it's possible. And we've done that. Also, that if one fails, you can go to the other, because the mechanism of action, the site of action is different. So it's not cross resistance. If Romi fails, you can go to Eltrombo fails, you can go to Romi. And then this was beautifully brought out by Nitin, that the route of administration is oral versus injection, which is a major decision making for the patient. This is daily versus weekly. This, of course, you have to reconstitute the powder, etc. The storage has to be remembered that Romiplostim has to be refrigerated, while Eltrombopag tablets can be kept at room temperature. And from the angle of toxicity, Romi is free from hepatotoxicity, which Eltrombopag has, but then it's an injection, which itself can be a problem for some people. So we move on with our patient, and the question will be to Neeraj and Sandeep now. So Priya opted for Romiplostim, and she was treated with weekly Romiplostim. As against the book teaching that you start with 1 microgram and increase with 1 microgram every week, in practice, there is no harm in saving time and starting with straight away 2, 3, or 4 microgram. And that's what was done for her. 2.5 microgram per kg was 125 for her. And that vial is now available. So that was the one which was used once a week. And then the dose was increased to 250 after 2 weeks, and then 500 after 4 weeks. Her platelet count was 4,000 before the treatment, 12,000 after 2 weeks, 18,000 after 4 weeks, and 46,000 after completing 4 weeks of 500 microgram once a week. And at 46, she was totally asymptomatic. So this is what has happened in the last about 2 months of her treatment, that now we are at 500 microgram once a week. Her count is around 46,000 and she's got no symptoms. So the questions are, I will go over one by one rather than mix up all the questions. First one is, what is your starting dose of Romiplostim in your practice? Neeraj?
Sir, thank you, sir. As you said, we started initially using Romiplostim with the generic Romiplostim trial, and in those times, the trial had the initial starting dose of 1 microgram per kg, then going up to 2 the next week, and no response going up to 3, etc. But outside the trial and in real world practice, we had to change that, and we felt, as you rightly said, something between 2 to 3 microgram per kg. Most often for a 70, 75 kg patients, we would round it off to 250 vial, 250 microgram as the starting dose. For a smaller patient like what you have mentioned in this Priya's weight, I think we would also start somewhere between 2 to 3 microgram per.
Thank you, Neeraj. Sandeep, any difference in your starting dose?
No, I think I will agree with it. And I think most of us are doing this because to save the wastage, means to prevent the wastage of the drug, because it is a costly drug. So most of the time, according to availability, now 125 microgram is available. So we start with 125 microgram and then we escalate the dose. So I think I will answer the second question, sir.
Right, you almost answered.
Yeah, so we escalate the dose weekly by 1 microgram, and if it is not possible, maybe by 2 microgram every 2 weekly.
Okay, so to both of you, the third question, how do you grade her response? She has reached up to 500, which is 10 microgram per kg, and now her count is 46,000, not normal, not bad, and she's asymptomatic. So if she wants to know, how have I done? What will you tell her?
I think it is a partial response. It is not a complete response, and she has to continue. She has responded this to the maximum dose which we can give to her, and that is 500 microgram if she is weighing 50 kg. So I think this is the maximum dose which we can give, and she has achieved a partial response. She has not crossed the 50,000 limit. So I will say she has partial response, and she has to continue the same dose for at least another 4 to 6 months.
Fair enough. And Neeraj?
So generally, when patients are started and then we discuss this, we tell them that our goal of therapy would be to achieve a platelet count of 50,000 to 200,000. And so that would be considered a good response. So here, as Dr. Sandeep sir said, I would also tell her that, yes, you have a response, but it's not a complete response. But we have to keep monitoring you over. It could improve in the coming weeks. I would monitor her continuously because you can often see it going up afterwards.
Fair enough. So as your goal was 50,000 and not 200,000, and when you say 50, it's probably 40 to 60 because you can't have a fixed figure. So with 46, this is a decent response what you wanted, and she has become asymptomatic. So I think you will be pleased and she will be pleased. The last part of the question to both of you is, in what percentage of patients Romiplostim is curative?
Yes, sir. Maybe I think Dr. Biju had answered this in his talk.
30%. So
20 to 30%.
You want to differ?
I think I would agree, sir.
You agree 30%. Sandeep? Sandeep, are you there? Okay, he probably has. Okay. So I would slightly differ. I would say 30% is a bit optimistic figure. In practice, it's not more than about 20% who can be really maintained at around 50,000 without the drug. So, okay, so those were the questions to these two, and now we have got raised hand. We start with Sanjeevan. Sanjeevan is...
Sorry, sir. I think I clicked on because I was very intently listening to the discussions between Neeraj and you. I think by mistake I No comment, sir. I totally agree with what Dr. Sandeep and Neeraj had mentioned.
Fair enough. Tulika?
So I also concur. The only thing I would differ is because her platelet count was only 4,000 and she'd been having significant bleeding. And now that we all have a lot of confidence with Romiplostim, and also from what I learned from Dr. Cooter's webinars, which had been hosted by you, for these patients, I would actually start at a higher dose, maybe at 5, 7, 8 micrograms per kg. And you can always see these patients back in a week. And even in those patients where they have a very exaggerated response in the first week, it is not dangerous and you can bring it down. So in somebody like her, I would probably have started at a slightly higher dose. But again, there's different ways of doing it, but it is very safe. And in fact, for all patients of mine who have less than 10,000, I try to do a higher dose, not less than 5 mics, maybe depending on their weight, I might be rounding it off. It might even be 7 or 8 micrograms, but otherwise I agree with the rest.
Yes, the rounding off is very important. There's no point in wasting this drug at all because no one knows whether she'll respond to 2, 3, 5, 7, 10. Padmaja? Unmute.
I had a similar thought about starting at a higher dose since the counts were very low. That is one thing. Second thing is, I know in a lot of studies, we're looking at complete response, 30% or 20% could come off the treatment. The whole idea of a chronic ITP is just to maintain a safer hemostatic platelet count. When we are on the 10 mics per kilo of a higher dose, why do we want to maintain such an aim, a 1 lakh count? So I would probably do, once they've reached 46, they would continue to rise as you go further. I would see them on a weekly basis and start reducing the dose. And I would want to maintain the counts about 30, between the 40 to 60 range, what we were talking about, rather than aiming to go higher and then come off, because this lady on a chronic ITP, the chances of her coming off the treatment after multiple lines is very low compared to the trials, what they've used. Is a kind of a good patients who have not used a lot of disease modifying agents, where they've failed steroids, IVIG, they've gone on to TPO. And our case is completely different, where the response rates and the way she could come off is almost in, less than 5 or 10%, what we could say. I just wanted to add that.
Absolutely, fully agree with you. In fact, I don't even, pamper them by telling that one day we will have 200,000 count. I always tell them, the just goal is 40 to 60. You achieve that, be happy, and then try to maintain it with the lowest possible dose. Don't want to go below 40, don't want to go above 60. And then from beginning, they are happy that, okay, they got their goal. Okay, there are some questions now which we will handle. Dr. Aditi wants to know that in such a refractory case which Priya has, will you do a bone marrow to confirm that this is really an ITP? So my answer is that yes, in a newly diagnosed case, you will always do a bone marrow because you may be suspicious of a wrong diagnosis. Over a year, probably you will get more and more confidence that this is probably ITP only, and you will rule out secondary ITP. And in elderly people, you can make mistakes with myelodysplastic syndrome. So yes, you do the bone marrow. My policy at the moment in adults is to do the bone marrow. Unlike pediatric ITPs, in adults, I don't take chances of not doing the bone marrow because some kind of marrow disease can always mimic ITP clinically. Comments from the faculty here. In adults, will you do bone marrow? This has been a discussion which can go on endlessly, but just very, very briefly, if somebody wants to comment.
As you said, sir, we always do, in adult patient, we always do bone marrow examination before starting steroids or any treatment in ITP, suspected ITP.
Fair enough. Padmaja, you want to say?
Unless it's a stable chronic ITP you're suspecting where you don't start treatment, you're just a wait and watch, I wouldn't do it. But at the time when you're starting, I think people are on alternative therapies. You don't know whether they've already had a bit of steroid. So I would, in a country like us, to be on the safe side. The follow-ups are not mandate. So yeah, I would.
Agreed.
Thank you.
That's such 80% of adults end up with a chronic disease. The second part of her question is, will you do an NGS panel in this lady? And this may be a bone marrow failure syndrome. So NGS panel for a lady of this age with a disease which has gone on. Anybody for it?
No, there is no reason, I would think. She's a young lady, the white cell count and hemoglobin is normal. There were no reasons. So we wouldn't do NGS. Despite you're giving TPO, there is a small chance that people think that they could increase the risk of leukemias or fibrosis, marrow fibrosis. But that's very theoretical. In a young patient, there is no concerns. We wouldn't do NGS. Even if you did find an MDS-related changes in NGS, they're not drivers, so you can't just diagnose them. So there's no role in doing them, I would think. Yeah.
Right. In fact, some of the patients have asked whether this causes myelofibrosis and leukemia, and my answer has been a strong no in clinical practice, as you said. Dr. Biju?
So just two comments. One is in terms of the NGS, unless the bone marrow clearly looks like aplastic, like Dr. Padmaja said, wouldn't do an NGS. The second thing is in terms of whether we would do a marrow, we have seen non-severe aplastic anemia. In a slightly older patient, we have seen MDS with isolated thrombocytopenia and of course TB. So for me, every adult, we should be doing a marrow.
Absolutely, I agree. Dr. Roshni wants to know, okay, that's a question which is unrelated to this discussion. We'll come back to this little later on. Okay, we'll come to these questions a bit later on. They're not directly connected. So we'll just move on now. Okay, so what this shows you that the response to Romiplostim and from same token Eltrombopag is in about 3 out of 4 patients. So there are patients who don't respond, and that's a sad day for that patient. We now move to the next part, and that's to Dr. Tulika and Dr. Dev Malya and Dr. Sanjeev. So after 2 months of weekly 500 microgram, she was seen in the emergency with severe abdominal pain. Investigation showed mesenteric vein thrombosis. At that time, her platelet count was 650,000 per cml. And we will take again one question at a time. The first question is, what will be your immediate management? She has come to you, she's got abdominal pain, this is her platelet count, she's on 500 microgram, and with a mesenteric vein thrombosis. So,
yes, sir.
I hope you can hear me.
Can others mute themselves? There is somewhere noise coming. Except Tulika, everybody can mute. Yeah, okay. Tulika, go ahead.
So thank you. So the management of such a patient would be to treat her for the mesenteric thrombosis, and she should be adequately stabilized, investigated, and given anticoagulation. Because her platelet count is 6.5 lakhs, there is no contraindication to anticoagulation. ITP patients are anyway at a higher risk for thrombosis. So that would be our immediate management.
Thank you. Dr. Dev Malya?
Yes, sir. I'm for inviting me. So my same point is that we should stop the medicine right now. Start Clexane or any Clexane will be better. Later on, we can move on to oral Noax or Doax like that. And was this avoidable? Yes, sir. It can be avoidable by serial monitoring and reducing the Romiplostim dose in time.
Okay. Dr. Sanjeev?
Sir, definitely we will stop the drug, and low molecular weight heparin followed by oral anticoagulation will be the treatment for this patient.
Okay. Dr. Dev Malya and Dr. Sanjeev, and probably Dr. Tulika, you said you will stop the drug. Do you all three feel that thrombosis was related to this high platelet count?
So I would differ. I would not stop the Romiplostim. I would taper it. And I would keep a watch on her platelet count, because in case her platelet count drops, then it will interfere with my anticoagulation, and I want to give anticoagulation. The studies by Dr. Puter and Sines, which had looked at thrombosis, they actually found the thrombosis with a wide range of platelet count. So it is, it can happen when the patients are thrombocytopenic. It can happen when the platelets are normal. It can also happen when the platelets are high. The other thing that I found very interesting in the Dr. Puter study, which Dr. Biju also quoted, was that a lot of the thrombosis occurred in the same patient. So the same patient can have multiple events. So it might not be just the drug. It may be many other things. We also know that, so one is that ITP patients have a higher risk of thrombosis. Second, a lot of the treatments may cause the thrombosis, but we also know it could be age, it could be other factors. And it's important to give anticoagulation. So if your platelet count is less than 30,000 or less than 50,000, then that will interfere with the treatment of the thrombosis. So there's really no need to panic. You can taper down the Romiplostim, keeping an eye on the platelets. Sometimes the platelet count may be reactive to the thrombosis. That may be high, or it may be due to the drug, in which case it's fine to let it drop a little. But we don't want the platelet count to go below the European guidelines, say 30,000. Many other guidelines suggest that in an ITP patient, you want to keep the platelet count around 50,000. We sort of aim between 30 to 50,000. The only contraindication to anticoagulation is life-threatening bleeding. Otherwise, anticoagulation is required, and tapering of the Romiplostim is fine, because there is no data to suggest that the incidence is that high. In most studies, the DVT and other things is about 1 per 100 patient years.
Right. So in this patient, one, you will not stop. And second, you will at least maintain the platelet count above 50,000, because you want to anticoagulate her for substantial period. This is mesenteric vein thrombosis. So it's a severely morbid condition leading to, it can go to portal vein, it can cause intestinal infarct, it can need surgery. So there are so many things with which you will be very scared of, and you will not allow the platelet count to go below 50,000 at least. The last part of the question is, this patient now gives a history that she had DVT in her only pregnancy. If this information was available to you in advance, would you have altered your decision about giving Romiplostim to this patient? So, Dr. Sanjeev?
Definitely no, sir. Probably some associated thrombophilia is there, and definitely for such patients, Romiplostim can be avoided.
Okay, Dr. Devmalya?
Sir, Romiplostim is a very good drug. On this regard, I could have thought giving some in lower dose, or more close monitoring of the platelet count, rather than not giving, avoiding it.
Okay, Dr. Tulika?
I think I would also agree. Earlier, when we first had the TPO RAs, we were kind of in many webinars, we discussed that if you had a high risk, somebody had an MI, you would avoid the TPO. But I think now that we've used them, we're very comfortable with them. And so I would not have not given her this option if this was something that she had chosen. But yes, perhaps a little bit closer monitoring, to not let her platelet count go high. But again, we don't know if this high platelet count was reactive, or it had been something that had been the TPO itself. But I don't think it's an absolute contraindication to a TPO RA.
Okay.
Sir, there are case reports of thrombosis with single dose of Romiplostim in high-risk patients. That's why I think it should be not used in high-risk patient.
Fair enough. There will be a concern, and the literature goes as if you have to look at where, what has happened, and why. So if it's an arterial thrombosis, you'll be more concerned. If it's a visceral and cortical thrombosis, you'll be more concerned. If it's a limb thrombosis, you can be a little liberal. And also, whether there was an obvious trigger factor for that thrombosis or not. If it was idiopathic, you'll be more concerned. If there was a trigger, then you will be less concerned. So it's a flexibility which has been shown in the literature. One part I missed. How often do you see the thrombotic complications following Romiplostim? Biju had answered that, but you people?
It's very rare.
Rare?
2%. 2%.
2%.
We have never seen, but the literature, as I said, it's about 1.1 per 100 patient years. So it is.
So I also never seen till now.
Now we'll go with the raised hand sign, Neeraj. All the questions, you can unmute yourself, Neeraj. So all the 5 questions, whatever you want to comment.
Sir, I agree with the immediate management of low molecular weight heparin because it's a organ-threatening thrombosis. Avoidable, possible, might have been avoidable. I'm not very sure about it whether it was avoidable because ITP by itself has a high risk of thrombosis, and this patient had a previous history of DVT in her pregnancy. Whether she has an antiphospholipid syndrome, I'm not sure. If so, whether we could have started some other treatment which caters to APLA. I was thinking like that. Is the thrombosis related to high platelet count? I'm not really sure whether the thrombosis, many of the thrombosis that we've had, both with L-Trombopag and Romiplostim, happened when the platelet counts were within normal limits, or sometimes when the platelets were very low. So I'm not sure whether it's related to high platelet count, although we have seen arterial vasomotor symptoms, just like in essential thrombocythemia, when the platelet counts have gone up to say 9-10 lakhs with Romiplostim. In some of those patients, those vasomotor symptoms had got relieved with low dose ecosprin. So I mean, I would put that question back to the panel here. And how often do you see the thrombotic complications? Rare. I've probably seen 5 or 6 thrombotic complications together with both from Romiplostim and L-Trombopag.
Okay, so I agree with the one thing that Neeraj said, that very high count lead to arterial thrombosis. I concur with you. I've had myocardial infarction in young lady with a count of 1 million. So it is a problem. Even if you caution them to keep monitoring the count, sometimes they don't come to you almost for a month. And suddenly from 50,000, they come to you with 1 million. Dr. Nitin?
Sir, completely agree with the point of monitoring. The other thing was probably worth looking at a background thrombophilia, and then she developed ITP. So that is something that we should not miss. So if she had a background thrombophilia and an increased rate of thrombosis in the background anyway.
Absolutely. 2-site thrombi, she had DVT during her pregnancy. Now she gets mesenteric vein thrombosis. In any case, mesenteric vein thrombosis necessitates that you look for the, and somebody had mentioned about antiphospholipid syndrome, which is relevant because of her ITP, but even the genetic factors. So she is a perfect case for doing proper workup. Anybody else wants to add anything? Okay, so we'll move on. So Priya was treated with LMW heparin. This was followed by apexaban. Workup for antiphospholipid syndrome and other prothrombotic disorders was done. It is negative. Romiplostim was discontinued at that time. That means once a week what she was getting was not given to her. After 3 weeks, her platelet count dropped to 180,000. And patient was asked to follow up every 2 weeks to see what next to do with Romiplostim. This is what was done for Priya. So besides the arm and the leg vein thrombi, you can get pulmonary emboli, and in situ pulmonary emboli have also been described. And this is a case of portal vein thrombosis as complication of Romiplostim treatment in a patient who had, of course, cirrhosis of liver with Hep C-related ITP. Cirrhosis, as you know, itself can lead to portal vein thrombosis. And those are some beautiful pictures showing portal vein thrombosis, all 3 of them. And this is the profile of the patient, starting of Romiplostim and diagnosis of portal vein thrombosis of that case which I showed you, which has been published in the literature. And this is L-Trombopag induced recurrent stroke in idiopathic thrombocytopenic purpura. You got first stroke, you got second stroke, you got third stroke by continuation of L-Thrombopag. And this is the side effect profile of L-Thrombopag. Infections, I don't know whether we see that, but non-serious infections 9%, rebound thrombocytopenia or hemorrhage 4.8%, LFT abnormality 7.6%, death 0.6%, may not be related, thromboembolic event, as everybody said, between 1 to 2%. I'm going to move to case 2 now. And we'll be beginning with Sanjeevan and Padmaja. Rahul, 52-year office clerk from Lucknow, diagnosed to have acute, probably this is symptomatic, acute symptomatic ITP of 1 week duration with occasional bruises and a drop of blood from the nose. Platelet count 22,000. The question, first one is, will you like to use Romiplostim upfront as the first line treatment in any patient, maybe Rahul? Sanjeevan?
Sir, sir, just covering the basics which we had already discussed at length in the previous case, that since he's a 52-year-old person, and when we say diagnose means we presume that we've already done a marrow and we are sure about the diagnosis. Now, this is a symptomatic thing because not only the platelet counts are low, this gentleman has got epistaxis. So, firstly, now Romiplostim has been FDA approved recently for use as a first-line therapy as well. The question whether we use it as a monotherapy or as a single agent is something to be discussed, because not just Romiplostim, there have been instances like with rituximab, even with L-Thrombopag. When we use in de novo, when the immune milieu is still not very much T cell driven, it is still B cell driven, the chances of getting a long-term remission with a combination of the two agents is pretty high as compared to a monotherapy. So this was the same thing of Dexa with the rituximab combination, or Dexa with L-Thrombopag combination, which had been getting used by many of our colleagues in recent time. So yes, if we will discuss the same things, we'll go through the same options which you had so nicely shown in the patient preferences point, whether long-term therapy versus oral versus subcutaneous. If the patient is good with a subcutaneous therapy and he is fine with Romiplostim, so I will offer this patient as an option, but I may be tempted to combine it with a short course of dexamethasone to probably increase its efficacy and achieve a long-term treatment-free remission.
So excellent that you don't mind using Romiplostim, but you will always combine it with the steroid, which will work faster. Romiplostim may take up to 2 weeks. So that's fine. Excellent. The news to me was that these drugs are approved first line. I didn't know that. They got approved, is it?
Sir, I read it in a recent review. I think Dr. Biju would be the more appropriate, but they recently got approved in as a first-line therapy in US.
Even I wasn't sure about that.
Okay, sir. I'll just, sir, I'll just try and find the reference because I read it randomly. In case I'm able to find, I'll just share that reference.
Sure. Okay. That's a very, very new news. Okay, so Padmaja.
I would slightly differ in the feeling with Dr. Sanjeevan. This patient, if he was severely thrombocytopenic, like single figure platelets, where I'm worried about just the steroid response and risk of a major bleed, then I would add a combination of steroids and TPO. But at this patient who has got acute ITP, not so much of a bleeding, a minimal risk, I would just start on a steroid as a first-line therapy rather than TPO. The fact that it's an acute ITP, there is a third of a chance that they could just go into remission rather than carrying on into a chronic, where there is a definitive role of treatment and stoppage. So I would start with steroids in this patient rather than going on with the TPO agonist as a first line.
Yeah, fair enough, Padmaja. Most of the people all across the world will start with steroids. If there is a medical emergency, then IV gamma globulin. And if IV NTD is available to you in some countries, IV, then you can use that. It will be a discussion whether you will add TPO analogs upfront day one in a newly diagnosed acute ITP. And whatever literature exists and whatever trials have been going on, they are from two angles. Number one, in long term, it could be steroid sparing. Because Eltrambopac, etc., Romiplostim take 2 weeks to work. So if you start them on day one, then after 2 weeks, they may become effective and you may be able to get rid of steroid faster. And the second is, which is of course a totally part of trial and hypothesis, as Sanjeevan put it, if you attack all the three, B cell, T cell, and the marrow, that means you give rituximab, you give steroid, and you give one of the TPO, all three together, whether you will achieve a change in the natural history of the ITP. That means, can you reduce occurrence of chronic ITP in adults? But that is a hypothesis, not yet proven. Boston group of workers are doing this trial. They presented it in ASH, but it will require years to follow up to see whether natural history of the disease got altered. So these are the two settings where I have seen TPO being used upfront. One is steroid sparing, getting rid of steroid faster. The second is whether it can change the natural history. The last part of the question is, how do you choose between Romiplostim and Eltrambopac? I think that has been addressed. So we'll skip it. If one fails, will you go to the other TPO-RA? In practice, if Eltrambopac fails, do you go to Romi? If Romi fails, do you go to Eltrambopac? Either of you, Sanjeevan?
Sir, I think that again was addressed because we can use either one of them alternatively. So if one fails, we can always go to the other one.
Padmaja?
Absolutely. The mechanism of action is slightly different, so you could interchange.
Only with one thing, that the efficacy in that situation is about 35 to 40%. It is not the initial like 75, 80%. Yeah, Sandeep, Neeraj, you have raised hands, yes.
Yeah, I think, sir, the efficacy, if we switch over from one to another, then the different retrospective trial, the efficacy has been shown to around 50%. And if it is switch over because of the intolerance to any one, then even the response rate is shown is higher, up to 70%. So, and we can easily switch over from one to another.
Sure. Neeraj?
Regarding the first question, in one of the instances where we have used upfront Romiplostim has been when an asymptomatic thrombocytopenic patient has to go for a surgical procedure. And then we would probably give Romiplostim. In a couple of patients, we have given Romiplostim weekly doses, 2 to 3 doses, and so the platelets come up and then they can be taken up for surgery. In most of them, the platelet count had been about 30,000 and not requiring otherwise steroids. So that's one instance which we have used Romiplostim as an upfront therapy. And second, as a steroid sparing agent, we have used it, as you mentioned, sir, but we've had some problems of overshoot of platelet count, especially in those patients in delayed response to steroids. Especially you add steroids, you wait for 7 days, and then you add the second agent as Romiplostim, but then sometimes you see an overshoot. So in such instances, we have kind of now moved to using MMF as the second agent. So those were the two things I wanted to tell, sir.
Okay. As the question of MMF has come up, which we were not planning to discuss, but I must tell the audience who are listening and students who are listening, MMF, cyclosporic azathioprine, and Dapsone have a success rate of about 20%, and they all take few months to work. So just be careful that these are not emergency drugs. Your patient should be stable. These are long-term cheap solutions, and they can only be discussed in the context of cost today in front of all these. They all came when rituximab didn't exist, TPO didn't exist, and of course, splenectomy was always there. Okay, anybody else wants to add anything? Padmaja, you?
I just wanted to ask in the discussion which Dr. Siddharth raised was a very good thing. Pre-operatively, could we give TPO, like a chronic stable ITPs who have a platelets about 60, 70,000 needs a surgery for a simple surgery. should we give a short course of steroids or should we give a TPO agonist? In a surgical context, there's always a risk of thrombosis postoperatively. So I have always favored low-dose steroids. In those chronic ITP patients, you give just 20 milligrams, they respond, and then you stop postoperatively, rather than giving a TPO and the risk of thrombosis. I've had one experience of a patient who had a splenectomy, who had multiple lines of therapy. In about 4 years ago, when the TPO agonists were much expensive, who couldn't afford a daily treatments and chose a splenectomy because of that. One of Arogya Bhadra, the police department patient, he developed a post-operative thrombosis after the splenectomy in the SMA, superior mesenteric artery, and he started having gut ischemia and bleeding, intubated. He got out, but it was a hard work. So the patients who had a normal count because of a TPO, who go for a splenectomy after multiple lines of therapy, are not going to be the same as the first line splenectomies or a post-op. So I think that's a learning point. One has to be aware the post-op thrombosis in a patient who had a TPO and a splenectomy or any surgery would be a bit higher than the normal, and they need a thromboprophylaxis.
Absolutely. I think you touched a very, very delicate point, which is not discussed so much in the literature. We keep talking about post-splenectomy infections, but post-splenectomy portal vein thrombosis, going into superior mesenteric vein thrombosis, pulmonary hypertension, all these things can be fatal, and one has to remember this. So it's not just infection. I don't think we have done any splenectomy in the last 15, 20 years for ITPs. Okay.
Sir, I just found out that reference.
You got it.
Yeah, so, I'll just read out this line because I can't share screen. It says that this is a paper by Nicola Cooper and Pussell. It's one of the reviews of 2021, which says just that the use of Romiplostim was recently approved in pediatric patients in the United States and European Union, and use in adults has been extended to include those with newly diagnosed ITP. That is what it reads. So whether we can call it an FDA approval, maybe the wording was inappropriate, but because I just gone through this paper, so and there are two very good references which they have quoted, calling their extension of use in adult patients, and those references I'm just coming down to, sir. Yeah, one is, of course, it's an Amgen, so it's a company sponsored thing, but one is EMA paper. It's a European Medicines Agency, Romiplostim summary and product characteristics. So these are the two references which they've quoted, in which they have started using upfront in newly diagnosed ITP in adults.
Fantastic, because that makes it, sort of official. Fantastic. Neeraj, Padmaja,
So I just wanted to add a word about the MMF, which also had a recent NEJM publication on the addition from the UK group of MMF to glucocorticoid as a first-line treatment in ITP. So, which had an increased response rates compared to steroid alone, but then had a decreased quality of life. So, so that was the reason why I mentioned MMF.
You are right. As Sanjeevan said, Nicola is a big name in ITP, and MMF is her baby. Nicola, it is MMF left and right, up and down, everywhere. It is her drug of choice. But we must remember that all that research was prior to TPO and prior to rituximab. And even today, if you ask her, she would say, this is my second drug of choice. So it's not that much used in US, but in UK, it has been popularized by her quite a bit. Neeraj? Or nothing?
Yes.
Okay.
So this is the Charlotte's paper on that September 2021, which I was quoting. Sir.
Okay, right. Anybody else, or we move? Okay, we'll move. Okay, so this is a public presentation in ASH last year. Abstract number: Romiplostim for treatment of adult patients with newly diagnosed or persistent immune thrombocytopenia is subgroup analysis from phase 2 study. And the conclusion drawn was, in this phase 2 study of patients with primary ITP, disease duration less than 6 months, Romiplostim demonstrated efficacy irrespective of whether patient had newly diagnosed or persistent disease. Efficacy outcomes were generally similar in both the groups of patients, and there was a rapid response within 2 weeks, and half of the patient had durable response. Respective TFR rates were 37% and 23% in newly diagnosed and persistent ITP. Safety was consistent across the group. No new safety signals were observed. This subgroup analysis was consistent with the previously reported overall findings of the study and support the use of Romiplostim in adult patients with primary ITP, including newly diagnosed and persistent disease. This was in December last year. This is interim clinical commissioning policy. Thrombopoietin receptor agonists as first-line therapy for new or relapsed ITP in adults and children over the age of 1 year during the COVID-19 pandemic. So during the COVID pandemic, they become liberal because to avoid the steroids. This is from NHS. And this is expert review 2020 Romiplostim in adults newly diagnosed persistent immune thrombocytopenia. This is British Journal of Hematology 2020, safety and efficacy of Eltrambopac plus pulse dexamethasone as first-line therapy for ITP. This is Eltrambopac and high-dose dexamethasone as front-line therapy in newly diagnosed ITP in adults. And you have a number of important things in the brief report in blood. And this is BMJ Open phase 3 randomized trial of Eltrambopac versus standard first-line pharmacological management of newly diagnosed ITP in children. And this is from Cindy Newnut. She has been very fond of using this drug upfront. This is switching thrombopoietin receptor agonist treatment in patients with primary ITP. We've been talking about that switch. Okay. So we move on. And we have a question for Dev Malya and Dr. Nitin Sood. Rahul was treated with steroids and Romiplostim. After 2 weeks, platelet count was 120,000. Steroids were tapered off over the next 3 weeks. And he's on weekly Romiplostim at the dose of 10 micro per kg, and platelet count is around 80,000. Rahul desires to discontinue Romi and take it as on demand. What is your opinion? And after a year of treatment, Rahul is finding the expenses beyond his financial resources. What is your suggestions? You can handle both. Start with Dev Malya. Dev Malya, are you there? Yeah, go ahead.
Hello. So am I audible?
Yes. Yes, you are audible.
Yes, sir. So my take will be, there are a few patients of mine, it's a personal experience, that a few patients who take on demand despite my structured advice regarding Romiplostim. So I have many patients, they tell lies. They tell that, yeah, I have taken the medicine, but I know that they have not taken. So either they are feared, somehow they are frightened, or somehow they think that the platelet is more than 50,000, I am not bleeding, so it will be on demand. So my opinion is that I keep the ball in the patient's court. I write on a weekly basis, but verbally at times I tell you may do what you want.
Fair enough. And the second part of the question. After a year, he is finding it extremely expensive. So what will you do? He's still not cured. He's got a platelet count on Romi 80,000.
So it's a difficult question to answer actually. So like the disease ITP, so they can stop or they can increase the gap. We can increase the gap and see how it works, because each patient is different. So a few patients may be on the same may maintain the same platelet count with some increasing the gap between two doses of Romiplostim.
So that is one way of reducing the expenses. Sure. Nitin?
I agree with Dr. Bhattacharya. I think Rahul will do what he wants, despite us telling him to continue. But probably at 80,000, we could be a bit liberal and ask him to reduce the dose or pace it out a little bit. Obviously, pacing it out has no evidence attached to it, but with more dose flexibility now, we can offer a reduced dose to him. so that he stays on the drug while he maintains a platelet count of more than 50,000. As for the second question, I think the reality in this country is that it's, despite the cost coming down, it's still a very expensive drug. And he's probably really struggling to afford even that. So the reality is, I think he'll be lost to follow up and stop taking the drug, or maybe even take it on demand. And we'll just have to deal with it as it comes.
So these are the cases where you go to the old age treatment, dapsone, azathioprine, all that. Okay. Biju?
I agree with you, sir. I would start him on either azathioprine or dapsone, overlap it for about 1 or 2 months, and then try and stop the romiplostim and just continue the oral drug. In about 30%, you will still get a reasonable response in terms of keeping it about 20,000-30,000, and that should be fine.
As Nitin said, we have a lot of poor patients and they have to still live with azathioprine and dapsone. Anybody else wants to say anything? Okay, there's no raised hand. So now we have questions for Padmaja, Neeraj, and Sanjeev. Initially, Rahul thought of going for splenectomy because he found that probably as the cheapest, because that could have been done free for him in a government or municipal hospital. So the questions are, is splenectomy risky for a patient who has received romiplostim recently? And do we need additional precaution during the post-op period, as Padmaja described a case already? And after splenectomy, if Rahul relapses with symptomatic ITP, then in a post-splenectomy situation, will romiplostim work and is it safe? So Padmaja?
So I think it is, the risk is there while he's on a big dose of TPO against romiplostim. So I would put him on thromboprophylaxis as his platelet counts are reasonable, and post-splenectomy, the counts are going to overshoot. So I think that's very important. With a 50,000, you take him through in a splenectomy, they are going to be more than 2-3 lakhs. So he would need a thromboprophylaxis. And in future, if he relapses again, we could reuse the romiplostim, but perhaps the response rates in non-splenectomized patients are much better than the splenectomized patient, as Dr. Biju George has shown us the data, but still the responses will be there. Yeah.
And one of the reasons for that is by the time you go for splenectomy, you've got a patient who's got a bad disease.
Absolutely.
So, the bad disease results will be bad. So that is one of the major difference why all these drugs do little inferior when they are used post-splenectomy. Neeraj, any differences?
Yes, I also agree with Dr. Padmaja. In splenectomy, we would be very careful when the patient is already on romiplostim, and we would go for a cautious thromboprophylaxis with low molecular weight heparin, and possibly also pre-surgical. When should be the romiplostim administered, and if we generally try to get over the peak platelet count before the splenectomy is done, and after immediate thromboprophylaxis with Clexane, sometimes we do, if the platelets are on the higher side, till they return back to normal, we often, and if they're ambulant and going home, we put them on a low dose of aspirin. And second, after splenectomy, if with a relapse of ITP, there is a decreased response, but obviously the responses are not too bad either. So I would definitely think of using romiplostim in symptomatic ITP.
Thank you, Sanjeev.
Sir, I usually do negative counseling for splenectomy to all patients who are relapsed refractory cases. But if at all splenectomy is needed, definitely under thromboprophylaxis, and we can use romiplostim after splenectomy, but obviously there will be less response rate.
Fair enough. Sandeep?
I think still the splenectomy is the most effective treatment, I think, whatever said. If everything fails, when still in many patients splenectomy works, so we cannot just remove splenectomy from the armamentarium of ITP. So post-splenectomy, I usually use aspirin for long time low dose aspirin. I don't know whether to use anticoagulant along with aspirin or not post splenectomy if platelet count is remaining higher, but we usually use aspirin.
You're quite right. I mean, giving rituximab every year or giving Romiplostim for the whole life for 80% of Indian patients, it's not possible. So splenectomy cannot disappear very easily from an unstable patient coming from a remote place with poor medical facility or when the pocket is empty. So you do find in government and municipal hospitals, splenectomy is the treatment for all these refractory bad patients of ITP, no doubt about it. And you are also absolutely right that aspirin is good enough post splenectomy. Hardly anybody will put them on anticoagulants. Tulika?
So I wanted to concur with Dr. Sandeep that yes, there are a few patients where splenectomy would be the best option, but the numbers are obviously reducing a lot. The second point I just wanted to make was when the TPO receptor agonist first got approval in the West, they were actually only approved in patients post-splenectomy. Now, of course, we have data to show that they are more effective when we use them in non-splenectomized patients. So I just wanted to put that information out for the second point, that even if they've had a splenectomy, there is no reason why they won't work. And perhaps the reason why they're not working is not so much because of the splenectomy, but because they've just had the disease for longer and failed more lines of therapy.
That's right. This is not because of spleen is out. It is because such patients are obviously more refractory cases. Biju?
I think I would say that splenectomy is still one of the treatment options available. If you compare a year of Romiplostim or Eltrombopag to the cost of splenectomy, and when we published our data about 5 years back, our response rates were close to 90% with about 10 to 15% relapse. So 70 to 80% still do very well with the splenectomy. So it's still an option available for patients. Yes, there are other drugs available provided they can afford it.
Right. I mean, the cost is the biggest deterrent. If you can afford a TPO agonist for the whole of your life, you won't like to lose your spleen. So it will be offered mainly to the patients who are either totally refractory to TPO or they just can't afford continuation of the treatment. So that will be the scientific place. In the beginning, it came post-splenectomy. So any new treatment is first in the third line, fourth line. To move to the second line, and now as was said, moving to the first line, it takes years. Any other raise hand? Yeah, Padmaja?
I just wanted to ask Biju sir, the splenectomy, what we gave about the response rates, about 2/3, and about you're quoting about 80 to 90%. This is all like patients who are using splenectomy as a second line post-steroid rather than somebody as a fourth line would.
No, so when we were doing splenectomy, we were using it in patients who would have failed steroids, Dapsone, and azathioprine. Before we actually went, of course, at that time, TPOs were not there. So it was after they failed all these three that we would do a splenectomy.
So those results, what we would quote, but the ones who have failed all these and going now for a splenectomy as a last option, the response rates and the durability of the response is not going to be what we would quote as before.
I agree.
What are the figures would you quote, Biju?
I would still quote 60 to 70%.
Yeah. They seem to respond, but they don't last for longer. All these refractory patients, when they go for splenectomy, they have a partial responses, but yeah, that seems to be the, yeah.
Blood published the article of 140 splenectomized ITP follow-up. At 10-year survival was 56%. So that was an eye-opener that if you have a follow-up of splenectomized ITP beyond 10 years, you have had death on your hand because of not just infection, because of thrombi and pulmonary hypertension. This article is a fantastic article in Blood, again by the giants. Okay, so this is the role of Romiplostim in splenectomized and non-splenectomized patients, saying that it works in both. And basically because splenectomy is done for patients who are bad, post-splenectomy Romiplostim will give little less good results because these are bad cases. This is safety and efficacy of Romiplostim in splenectomized and non-splenectomized ITP. So safety and efficacy. Follow up on Rahul. After a lot of consideration, Rahul agreed not to undergo splenectomy. He took 4 doses of rituximab, 100 mg because of the cost factor. Now this is about 11 months after the treatment and his platelet count is over 200,000. So this is just to introduce the subject that there are people who can be managed in a very cheap way with a single 100 milligram dose of rituximab, 4 doses, and it works. Of course, you cannot make it as a generalization because there is no comparison with 375 milligram per meter square, but in a non-lymphoma patient, maybe this is good enough. We move to case 3. And this is to Dr. Tulika, Dr. Sandeep, and Sanjeev. Nikita, 25 years old from Delhi. Second pregnancy, 9th week. Known case of stable primary ITP, off treatment and maintaining platelet around 90,000 without any treatment. She was now seen in the 9th week of her second pregnancy with the platelet count dropped to 12,000. No other causes of low platelet count found. She refused to terminate her pregnancy. So how will you manage now Nikita through her 9th week to the full term and the delivery? And does she have an option of taking Romiplostim? So we start with Tulika.
So excellent. So she's already a known case of ITP. And we do often see that when they get pregnant, often they can have a relapse. Many patients would have been in remission prior to the pregnancy. So this is not an uncommon phenomenon. Fortunately, in India, we have the Janani Suraksha JSSK Karyakram. It's a scheme for pregnant women. And through that, we are able to manage these patients with IVIG. And in patients, if the response is lost, which we sometimes see after 3 weeks or so, we can even repeat it. So one option is to continue her on IVIG. Some patients just need it, when their platelet counts are less than 30,000. Steroids, again, is approved. Steroids, we try our best not to use very high doses of steroids because we're worried about infections, but many patients will respond to a 0.5 or so dose of steroids. Azathioprine is also approved, though we tend not to use azathioprine. In our pregnant ladies, we prefer to use steroids, IVIG, sometimes a combination of those. And if they're not bleeding, we tend to accept lower platelet counts. Towards the time of delivery, we try to attain a higher platelet count. The second part is Romiplostim. So obviously, these agents are not approved in pregnancy, but during the COVID time, we did have a few patients who were pregnant and who were not responding to IVIG and steroids. And we have had some off-label use of Romiplostim. My experience is small. We've only used it in 2 patients. But in both of those patients, we did get a response and we were able to safely deliver the babies. And there was no complications either in the mother or the baby.
Thank you. Sandeep?
I think Dr. Sandeep had to leave. His daughter has cleared MD today.
Okay. Congratulations to him. And Dr. Sanjeev?
Definitely, sir. As it is a first trimester, 0.5 milligram steroids will be my choice for treatment of this patient. And at the time of delivery, prior to delivery, IVIG can be given. Romiplostim, definitely, it's not an approved drug for pregnancy. But some off-label publications are there, and we have also used Romiplostim in pregnancy, especially 3rd trimester before delivery. Patients who are not able to afford IVIG, and we have good results. So that is my call.
Thank you, Dr. Padmaja.
I echo most of the thoughts what everybody had said. There is no off-label usage of TPO agonists. But one thing I want to make it in the 1st trimester and 2nd trimester, our aim of keeping the platelets are only about 20,000. We don't have to aim to have a very high levels. And we would continue to monitor the platelet counts on a monthly basis in a stable patient. and give a low dose steroids, about 20 milligrams of PRED, to see most of them do respond. The non-steroid responders are the difficult ones. And we aim to have, since they hit a 30-week pregnancy, from that time they have a weekly platelet count, and we would want to start planning their pregnancy and delivery, whether it's going to be section, normal delivery, what is your targeted platelet count, and how much dose you want to give. And again, post-pregnancy, delivery time, risk of thrombosis, one has to be aware of. And the bleeding risk is much low in the first and second trimester. Once you are hitting 30 weeks, that's the time you want to aim to have the platelet counts about 50 if it's a normal delivery, about 80 to 1,000 if you're looking at epidurals or section, and so on.
Absolutely. I fully agree with what Padmaja said. We have used very little IV gamma globulin because the effect is only for 2 weeks and it's very expensive. And as Padmaja said, the goal of just keeping the count at 20,000 for the first 2/3 of the pregnancy is good enough. It's the peri-delivery management which becomes the most important, and which everybody has covered beautifully. And there are enough reports of both Altrambopag and Romiplostim being used very safely during second and third trimester. Now the numbers are so large that I would say you can take it as an off-label use, and the fear is bit disappearing. There is no other raised hand, right? Okay, sorry. What happened? Okay, so Nikita was managed with steroids. 2 weeks prior to the planned delivery, she was given a course of IV gamma globulin, 1 single dose of 1 gram per kg. With near normal platelet count, she received epidural and underwent full-term induced vaginal delivery. All deliveries in ITP have to be planned. And the newborn was monitored for the platelet count first 2 weeks, and there were no issues. This is effect of TPO agonist on pregnant mice from Japan. Conclusion was the use of TPO agonist is limited for ITP in pregnant women due to the concerns about fetal toxicity. In this study in the mice, we examined the effect of Romiplostim. Romiplostim increased the platelet count and megakaryocyte count in pregnant mice at all the doses, and in fetuses at doses about 10 microgram. The dose of Romiplostim used clinically for ITP did not show any adverse effect on the pregnant mice. Although the results of present study are encouraging, until there are more conclusive data, the use of Romi should be evaluated individually in severe life-threatening cases, and all relevant ethical aspects should be considered. This is use of TPO agonist in pregnancy, a review of literature. What does it show? The purpose of the study was to review the literature to evaluate the safety of these in pregnant women. 10 case reports and a cohort study pertaining to the use were obtained. According to the reported cases and prospective study, the use of Altro or Romi appeared to be relatively safe in the first, second, and third trimester, as there were no reported congenital malformations. Low fetal birth weight has been observed following administration of Altrambopag during second trimester, whereas premature birth has occurred following the administration in the third trimester. Both appear to be relatively safe. Further studies are needed. This is TPO agonist in the treatment of ITP narrative review in Therapeutic Advances in Hematology published last year. What it says is our review of literature suggests that TPO RAs can help raise the platelet count within 2 to 3 weeks during pregnancy. In the light of existing literature, it seems that the use is safe in the second and third trimester. However, their use during first trimester when organogenesis at its peak must be avoided till further evidence comes through. The current literature does not suggest any antibody effect of TPO-RA in late pregnancy on the fetus or neonate. This is a Chinese product which is not Altrambopag or Romiplostim, published 5 years ago, a novel TPO agonist for the management of ITP, and that's a commentary on that by James Bussell, TPO for ITP in pregnancy. But 5 years down the line, we haven't seen any further publication on this compound outside China. Case 4 to Sanjeevan and Sandeep. Venkataraman, 48 years, from Kochi, undergoes an allo transplant for AML. Post-engraftment, he is struggling with thrombocytopenia. And is there a role for Romiplostim in managing post-transplant thrombocytopenia? So only Sanjeevan is there.
Yes, sir.
Go ahead.
Sir, I think before we started the talk, we had this discussion, informal discussion with Dr. Biju also. Now we are getting formalized. Of course, as of now, there is a clear-cut reported number of reported literature where the romiplostim can be used definitely in post-engraftment thrombocytopenia. Now there is talk about pre-engraftment, but that's a matter of research. But definitely, without any question, the answer is yes.
Right. Anybody wants to add anything?
And the dose here, sir, yeah, the dose here will be slightly on the higher side because this is not a ITP, because in post-transplant thrombocytopenia is like a combination of because of the conditioning regime, GVHD, microangiopathy, multifactorial. So unlike in ITP where we may start with a very low dose like 2 or 3 or 4 mics, here we may need to probably start at 5 and quickly go up to 10.
Thank you. Padmaja? A raised hand sign was there, but
sorry, sir. Yeah. Yes, you could use it, but there is always that little risk of reactivating leukemia. If it was a myelofibrosis patient, non-leukemic, it is much nicer and easier in a aplastic patient to use. But that little concern is there if it's an early part of pregnancy, early part of transplant period. But if it's severe, then yes, you would use it. If it's below 20,000, you're struggling with a GVHD, a lot of GVHD on board. If you're thrombocytopenic, yes, I would use. If it is, there is no massive GVHD borderline, I wouldn't use. I would wait for the counts to recover. Yeah. But it does work when you.
It does work, and in most of the big reviews, the incidence of myelofibrosis with romiplostim has been between 1% and 3%. So naturally, when we be using in post-transplant thrombocytopenia, it will be a rather disparate situation, like yes. Multiple platelet transfusions and all that. So at that point of time, we may need to take this 1% to 3% risk of fibrosis.
And when you say 1% to 3%, most of that is clinically insignificant.
Clinically insignificant, yes.
In the trial period,
in the and that too in the reticulin stains.
Yeah, when they were doing regular bone marrows as a part of the trial, they picked it up. And the recommendation today is, unless peripheral smear suggests that there is some change, teardrop poikilo or leukoerythroblastic reaction, you do not do bone marrow to look for asymptomatic or
fibrosis.
Bone marrows, yeah. Okay, so this is a publication, Romiplostim in patients undergoing HSCT, results of phase 1 and 2 multi-center trial by Régis Letov from France. And these are the platelet improvements in patients who received Romiplostim after HSCT. From day 20 to day 80, platelet going up from negligible to over 80,000. Conclusion was Romiplostim can be safely given to patient with transfusion-dependent thrombocytopenia following allotransplant. It was able to improve the platelet count using dose more than 5 microgram per kg, as mentioned by Sanjeevan, to reach the platelet count of 50 or above at a median of 45 days. Therefore, Romiplostim is particularly interesting considering the increasing use of alternative donor transplant and the high rate of toxicity related to delayed platelet recovery and secondary thrombocytopenia after HSCT. This is another one, use of thrombopoietin receptor agonist in prolonged thrombocytopenia after hematopoietic transplant from Ohio. And the conclusion was almost similar. We go to the case 5 to Nitin, and Devmalla is not there now, Nitin. Suhasini, 48 years, metastatic CA ovary. Medical oncologist is struggling to give next cycle of chemo due to persistent significant thrombocytopenia. Any role of Romiplostim? Nitin is there? Or
Sir, I think Nitin is not there. I can't see his name.
Padmaja, you got a raise hand sign. You want to answer?
I think this question is straightforward. Yes, we could avoid dose reductions and delaying in chemotherapy. So I think it's a straightforward approved indication we could use. Yeah, there would be no concerns.
You use the word approved?
I mean, it is now in CIT, it is approved as a chemotherapy induced, especially in solid organs.
Is it approved, is it?
I thought that's what we were looking at indication.
Sir, I'll again search it up, but I think it is approved.
Approved, okay. So Suhasini was given next cycle of chemotherapy under platelet support. This is a multi-center study of Romiplostim for chemotherapy-induced thrombocytopenia in solid tumor and hematological malignancies. And last author, as you see, is Putter. And conclusion was Romiplostim is effective in management of CIT in patients with solid tumor, as demonstrated by improved platelet count and low rate of chemotherapy dose reduction and treatment delay, bleeding, and platelet transfusion. VTE rates approximated rates in similar cancer population not receiving Romiplostim. Weekly dosing resulted in improved outcome as compared with more intermittent intracycle dosing. Romiplostim was generally ineffective in patients where bone marrow was invaded by tumor, patients who have received previous pelvic irradiation, and prior exposure of temozolomide. So these were three conditions where Romiplostim did not work. These are schedule which can be used for giving Romiplostim. And this is NEJM Journal Watch, a thrombopoietin receptor agonist for chemotherapy-induced thrombocytopenia. It was, pros and cons. It wasn't really straightforward recommendation. It had given the points in favor and against. And,
yes, sir.
Yeah.
Sir, I stand corrected. Yeah, there is no approval. This just says that it is a practical finding, and whether it will translate to approval, it's a practical finding that it has multiple studies which support the use of Romiplostim in chemotherapy-induced thrombocytopenia, but not yet approved.
And this NAJM watch out says, evaluation of TPO-RA in management of chemotherapy did not demonstrate any benefit after administering Eva-Trombopag before and after chemotherapy, and they suspected that the lack of benefit was related to higher than expected rate of spontaneous platelet recovery in the placebo group. So that may be the interest in concluding. They also suggest the results could have been affected by the exclusion from the study of patients with prior chemotherapy-associated thrombocytopenia. Although it is safe, a lack of statistical efficacy limited the use. Okay. We go to case 6, and that's to Neeraj and Tulika, Madhav, 3 years, Chennai. Bruising, eczema, frequent infection, mild splenomegaly, diagnosed with Scott Eldridge, sorry for the spelling error, platelet 30,000. Is there a role of Romiplostim in inherited thrombocytopenia? So Neeraj?
I think I've not used in inherited thrombocytopenia, but I've come across some literature on this. I think it's not approved, but people have shown benefit in decreasing the bleeding symptoms and temporarily improving the platelet count, especially in patients who are, later transplanted. So I have come across a few articles thus, and that generates a lot of interest, but I haven't used it myself.
Fair enough. Tulika?
So, and there is a very nice review by Bastida on using Romiplostim in inherited, all TPO receptor agonists in inherited thrombocytopenias. And particularly in Wiskott-Aldrich, they say that patients can have up to 20 to 30% response rates. And even in those patients where the platelet count did not significantly increase, they say that there was a decrease in hemorrhage. But at the same time, though it may work, but they say to avoid using it for long term and to use it around time when they are having bleeding or procedures or surgery. So in the review, they had actually looked at patients with other inherited thrombocytopenias, including congenital amegakaryocytic thrombocytopenia and the MYH9 and other syndromes. And there seems to be a role of it in some of these diseases where the thrombopoietin activates the JAK-STAT pathway and can lead to increase in megakaryocyte production. But again, this review kind of cautions because there are some inherited thrombocytopenias where there is also an increased risk of malignancy. And I think that's why they don't say to use it the way that we do it in ITP, where we're using it regularly for a long term. And they suggest using it intermittently, but it's definitely a very new and interesting area, and it opens up some new questions. But we must be aware that this is not going to be curative for these disorders. And as Dr. Neeraj had said, these patients, the only curative therapy for most of them will be bone marrow transplant.
Thank you. Dr. Padmaja?
I think Dr. Tilaka has eluded all the evidence, so I have nothing more to add. Thank you.
Good enough. So Madhav was helped with Romiplostim, and he just undergone hematopoietic stem cell transplantation. So you have patients who are symptomatic and their transplants are not tomorrow. So in between, you can definitely do some help to them. This is role of thrombopoietin receptor agonist in inherited thrombocytopenia, published very recently. And the conclusion is there is evidence for the use of TPO-RA, not only in other forms of ITP, but also in inherited thrombocytopenias. We have reviewed the literature that existing evidence on the role from 2010 to 2021. Overall, 24 articles were included, 4 clinical trials, 3 case series, and 17 case reports. A total of 126 patients of inherited thrombocytopenia were treated. The main diagnosis was Viscott-Eldridge syndrome, MYH9 related disorders, and ANKRD26 related thrombocytopenias. Most patients were enrolled in clinical trials and were treated for short period of time as bridging therapy towards the surgical intervention or for the transplant. In conclusion, the existing data indicates that TPO-RA can be an effective treatment, especially in those IT-related defects in cytoskeletal assembly, proplatelet formation, and when there is a reduced platelet lifespan. Despite a well-established predisposition to hematological neoplasms in patients of ANKRD26-RT, short courses of TPO-RA are safe when you're using it just as a bridge to surgery or a bridge to transplant. And this is off-label use of TPO, case series and review of literature. And I urge everybody to read this article because approved uses we have discussed off-label are very interesting because that is what you do in practice, left and right. And conclusion of this article is, we report 10-year real-life single-center experience off-label. Patients were divided into 3 groups: MDS, post-transplantation, and lymphoproliferative diseases. TPO-RA were effective in all these 3 conditions. The overall response rate was 100% after transplantation and with lymphoproliferative diseases, and 75% in patients of MDS, without any grade 3 to 4 adverse effects, without any thrombosis. In our real-life experience, TPO-RA are effective and safe and of proven value in these conditions. So in the era of TPO-RA, this is my last question, is the policy of wait and watch for a child who's got a platelet count of 30,000 justified? So I'd like to ask you before my opinion. In the era of TPO-RA, if there is a child with 30,000 count, not bleeding, is the policy of wait and watch justified? First of all, yes and no. How many for yes?
Yes.
Yes.
Yes, yes, yes. Anybody for no? Nobody for no. So let me show you this. So this is Nicola Cooper, everybody's favorite today. The child with ITP, to treat or not to treat, is that still the question? And the question that they've raised are these. At currently, you favor no treatment, as everybody said today, because spontaneous remissions are common. The risk of intracranial bleeding is very little. Treatment is not usually curative. There is very often need for the rescue medication, and there will be side effects and the cost of the treatment. On the other side, failure to remit, 20%, recurrent minor bleeding keeps occurring. There's a tremendous activity restriction. We've got a child of 30,000, you tell him don't do this, don't do that, don't play. So it lowers the health-related quality of life. So with the advent of TPO-RA, which are simple, oral, very, very safe and powerful, effective drugs in 80% of patients, probably you go in favor of treatment because they've got high response rate, This will reduce the activity restriction, and therefore it will improve the quality of life. There will be less need to the rescue medications, and the side effects are negligible. On the other hand, you may still say no treatment because inconvenience of the treatment, cost of the treatment, and you can always compare long-term benefit and risk. At this debate, I think we come to an end. Thank you so much for participating. Padmaja, you want to say something? Yes.
Oh, sorry. Did I put the, sorry. Yeah.
No, okay, you don't want to say anything. There are some questions in the question box. I've read them and they are exactly what we have discussed. So I'm not going to take them up. On behalf of organizers, I thank everybody and hand over the task to the organizers themselves. Back to Alkem.
Thank you, sir. And I will like to thank all the faculties today for the very engaging session. First of all, our chief guest, Dr. Sharad Damodar, and our guest lecturer, Dr. Biju George. And thank you, MB sir, for a very engaging, very informative, and it was eye-opener discussion on case-based discussion on Romiplostim treatment in ITP and beyond. I will also like to thank all our panelists, Dr. Deba Malya, Dr. Neeraj, Dr. Nitin Sood, Dr. Padmaja, Dr. Sachin Jadhav, Dr. Sandeep Shah, Dr. Sanjeevan Sharma, Dr. Tulika Sheth, and Dr. Sanjeev from Lucknow. So thank you all. And last but not the least, I would like to thank all the delegates today for attending the session and very actively asking a lot of questions. Thank you all and wish you all a very good night. Thank you very much.
Thank you for putting us together and good night.
Right.